بسم الله الرحمن الرحيم. طبعا بشكر دكتورة غادة على التقديم، وبشكر حبيبتي دكتورة غادة الصغيرة على دعوتي، وحبيبة قلبي برضو دكتورة غادة عبد الرحمن، والأخ العزيز جدا على قلبي دكتور خالد يوسف. حقيقة كلهم حبايبي، ما أقدرش أقول لا، لو آخر الدنيا هاجي لكم. فيسعدني وجودي في المنيا، وبالصعيد اتشرفت قوي قوي بوجودي مع حضراتكم، ويا رب التوك تعجبكم إن شاء الله. بشكر ساديكو على سبونسرنج السيشن دي. الحقيقه احنا هنروح بقى من الثايرويد والدايابيتس للشورت ستاتشر. احنا الحقيقه الشورت ستاتشر عندنا في البيدياتريك اندوكراين بنسميه البريد اند باتر، يعني اكتر حاجه بنشوفها واكتر حاجه بنشتغل فيها. فهحاول اخلي السيشن انتراكتيف على قد ما اقدر، وهحاول اجاوب على سؤال مهم كلنا بنتعرض له: the short child to treat or not to treat with growth hormone. Let me open the scene by this interesting cartoon. We as endocrinologists face patients or children coming and asking this very common question: am I short or not? ممكن المايك Am I short or not? And as you see, most of the children lie at the middle of the bell chart, with some of them being extremely tall and others being extremely short. And from here came the definitions of short stature. And this is a height below -2 standard deviation or third percentile for age and sex, height more than 2 standard deviation below mid-parental height, growth velocity less than -2 standard deviation or 25th percentile, and finally height deceleration crossing 2 major percentile lines. And this is a really difficult question, how to think right about a case of short stature, because it's really not simple dealing with a child with short stature. We could be stuck in the heavy traffic in answering this question. Why is the child short? When evaluating a child with short stature, we have 3 main categories: either dysmorphic child, and this is the category of syndromic short stature, the disproportionate short stature with achondroplasia and hypochondroplasia being on top of the list. And if the child is proportionate and not dysmorphic, we have to exclude normal variants, undernutrition, chronic illness, SGA, and finally endocrinal disease. And if we're facing none of these, we are left with idiopathic short stature. And this is the algorithm proposed by European Society for Pediatric Endocrinology. When facing a child with short stature, as we all know, we start by physical examination, and then we go anthropometric assessment, baseline investigations, thyroid profile, growth hormone stimulation test, and we need 2 growth hormone tests to diagnose growth hormone deficiency, IGF-1, and the final step is genetic studies and whole exome sequencing to reach the final diagnosis of short stature. And here it's very important to note, be careful not to fall in the pitfalls in the diagnosis and treatment of short stature when dealing with a short child. First of all, avoid basal growth hormone measurement. It's of no use because, as you know, it's a pulsatile secretion. So we have to do 2 growth hormone stimulation tests to diagnose growth hormone deficiency. But there are some few exceptions when we do only 1 growth hormone stimulation test, and sometimes we do not need to do the test. Thyroid function should be done prior to growth hormone stimulation test. And if the child has hypothyroidism, we have to correct the thyroid function. Otherwise, you're going to have falsely low growth hormone stimulation. Karyotype should be done in any short girl, even if not dysmorphic, to exclude Turner syndrome. Bone age does not indicate a definite diagnosis, and a normal bone age excludes endocrinal disease. MRI cella turcica could be the clue for diagnosis. And finally, exclude normal variants, nutritional disease, chronic illness before jumping to the diagnosis of endocrinal disease. And this is what I call the short child panorama. Here you can see a lot of cases. All are real life case scenarios presenting with short stature, but the scenario turned out to be totally different in each and every child. The first question, is the child really short or not? By plotting on the growth chart, exclude normal variants, investigate for pathological disease, and finally, treat according to the cause. So as we all know, prescribing growth hormone is very easy. It's easy for each and every one of us to write down growth hormone for the short child. And the question here, is it just giving growth hormone to treat any growth disorder? Yes or no? Do you think that it's the magical stick that would solve the problem of any short child? Thank you very much. Of course not. We have to treat according to the cause. And we have to be very cautious and careful when prescribing growth hormone. So the question here when facing a short child is, who will benefit from growth hormone therapy? And this is what we need to answer in this talk. In other words, which way shall we go? To give or not to give growth hormone in every short child? I'm going to show you real life scenarios, and I'd like you to help me in prescribing growth hormone or not in each child. And we need to grow right, because the question is not just giving growth hormone to make the child grow. The question is how to grow right. Prescribe growth hormone when indicated, because growing right is our target, not just giving growth hormone. Now, looking at the history of growth hormone was first isolated from human pituitary in 1956. In 1958, it was obtained from cadaveric pituitaries. In 1960, it was clear that growth hormone deficient children would benefit from growth hormone. And in 1985, FDA received reports of its association with a serious neurological disease, and this is the Crutchfield-Jakob disease. And this year witnessed a switch from the cadaveric growth hormone to recombinant growth hormone obtained by DNA techniques. So this is the history of growth hormone, or this is what happened in the past. Now, what is the current recent future? This is a list of the approved indications of growth hormone therapy in children and adolescents. You can see two boxes. The first box is FDA approved indications, and the other box is that approved in Europe, and this is the EMA. You can see that it's a copy paste, except that idiopathic short stature is approved by FDA and it's not yet approved in Europe. Another new indication that was recently approved in Europe is Noonan syndrome. It's recently approved in 2020. Now let's start by the 7-year-old girl who came to me with proportionate short stature. She was born with a normal weight and length. Her height is very short, -4.5. Growth velocity, 2 centimeters a year. She has doll-like face with excess abdominal fat and normal IQ. If you look at the growth chart, you can see that the girl started to decelerate at the age of 3 years, and then she started to plateau her height. Her celiac screening, thyroid function, cortisol, ACTH, normal. The growth hormone stimulation by 2 tests revealed very low growth hormone test, and the IGF-1 is very low. The bone age is delayed. She's 10 and the bone age is 6. What's your diagnosis? A very straightforward case. Thank you very much. This is isolated growth hormone deficiency. And when we did the MRI, we found anterior pituitary hypoplasia. And here you can see the criteria proposed by Growth Hormone Research Society for Diagnosing Growth Hormone Deficiency. And most of the references agreed on a cutoff of less than 7 nanograms per ml to diagnose growth hormone deficiency. And you can see that there is inter-assay variability. So it's very important to take the assay into account. Now, what happened to this girl? Now, let me ask you, would you like to give growth hormone or not? Yes or no? Of course, yes. This is the first approved indication for growth hormone. And look what happened when we gave growth hormone. She beautifully grew and gained very good height, as you see. Here, it's very important to note that the dose of growth hormone differs in different phases of life. You can see the dose in children, 0.025 to 0.035 milligrams per kg per day, a different dose in transitional period, and totally different in adulthood, which is needed for metabolic purpose. Also, replacement of other pituitary hormones is very important in addition to growth hormone to optimize the final height. Now, what do you think? What is the correct sequence? Which gland should we start with? Thyroid, adrenal, growth hormone? Adrenal. We start with the hypoadrenalism first, and then we correct the thyroid gland, and then the growth hormone, and finally, sex steroid if the child has hypogonadism. Another FDA-approved indication is the infants born small for gestational age. And this is a birth weight or length below 2 standard deviation below the age and sex. Around 5% of newborns are born small for gestational age. And these are classified into 3 subclasses, either SGA regarding the length or the weight, or both weight and length. Now, let me take you to the story of this full-term neonate. He was born SGA 1.2 kilograms. His height minus 2.8. His BMI is normal, and the mother came to me at the age of 1 year requesting growth hormone therapy. What do you think? Shall I take the mother's advice? Would you like to give growth hormone to this very short baby at the age of 1 year? Thank you very much. Of course, no. We do not give growth hormone at this age in SGA. We have to wait until the age of 2 to 4 years. If the child does not catch up, you give the growth hormone. So the prognosis is excellent in those children. 85 to 90% catch up spontaneously at the age of 2 to 4 years. So we have to wait. 10 to 15% will not catch up and will need growth hormone therapy. Now, looking at the alterations in the growth hormone IGF axis in SGA, most of them have growth hormone resistance. Some of them have IGF resistance, and very rare to have growth hormone deficiency. And please remember that growth hormone therapy increases the final height in SGA by 1.25 standard deviation and normalizes the body composition. And the growth hormone is approved both by FDA and Europe until complete epiphyseal closure. And you can see that there is a debate on the age of start. FDA recommend to start at the age of 2 years, while EMA recommend starting at the age of 4 years if the baby did not catch up the height by this age. You can see here that long-term growth hormone therapy, in short, SGA children, optimizes the final height, and they need larger doses, which is higher than in growth hormone deficient children. And it's clear here that there is deceleration or down growth if you stop growth hormone in infants born small for gestational age. Another important thing is that SGA predisposes to metabolic syndrome. SGA causes alteration of metabolic programming, redistribution of nutrients, and this leads to changes in glucose metabolism, ending by obesity, type 2 diabetes, abnormal glucose metabolism, dyslipidemia, and hypertension. So it's a risk factor for metabolic syndrome. So growth hormone improves the metabolic profile in those children. Indeed, it improves the final height. In addition, it improves the lipid profile, the blood pressure, it increases the lean body mass, decreases the fat mass, improves the IQ, and the bone mineral density. So it has a lot of beneficial effects in infants born SGA. What about this 13-and-a-half-year-old girl who came to me with short stature, -3.5 standard deviation? She has delayed puberty, Tanner stage 1. She was born with a very low birth weight and length, swelling in her dorsa of hands and feet, mathematical problems at school, and recurrent otitis media. Now, looking at the chart of this girl, she was born very short since birth, and she continued to be below -3 standard deviation until the time I saw her at adolescence. Her thyroid function, growth hormone stimulation, celiac are all normal. The bone age is delayed, as you see. The GnRH stimulation test showed high FSH, high LH, low estradiol. So this is hypergonadotropic hypogonadism, meaning that there is a problem with the ovaries. She also has a partial horseshoe kidney and the echo is normal. What's the missing investigation here? Yes, thank you very much. This is a very important investigation which was missed by pediatrician. It should have been done from the beginning. Don't wait for dysmorphic features. And the girl was found to have Turner syndrome, 45X Turner syndrome. And here you can see, based on the guidelines published in European Journal of Endocrinology 2017, you have to do a karyotype in any girl with short stature, delayed puberty, primary amenorrhea, left-sided cardiac disease, or lymphedema. So don't wait for dysmorphic features. Short stature in Turner syndrome occurs due to haploinsufficiency of the SHOX gene. And those girls have growth hormone resistance rather than deficiency. And that's why they need very large doses of growth hormone. And if you have the result of the karyotype, there is no need to do a growth hormone stimulation test. So Turner syndrome is one of the indications where you do not need a growth hormone stimulation test. And as you see, SHOX gene increases the chondrocyte proliferation and the cartridge matrix synthesis. And therefore, SHOX gene mutation leads to short stature, premature closure of the epiphysis, ending by disproportionate short stature. And here you can see some of the skeletal features in Turner syndrome: short metacarpals and scoliosis. And this is the Madelung deformity, which is the shortening of radius, bowing of radius, and the V-shaped angle between radius and ulna. Again, the skeletal features point towards Turner syndrome. So let me ask you the same question: to give or not to give growth hormone in this girl with Turner syndrome? Who would like to give growth hormone? Thank you very much. Of course, it's an FDA-approved indication and approved by Europe as well. Yes, we gave growth hormone and the response is excellent, as you see in the growth chart. And these are the clinical practice guidelines showing you the dose of Turner syndrome: 0.045 to 0.05 milligrams per kg per day, 7 days per week. It should be given daily, subcutaneous at bedtime. And you can see that this is a strong recommendation. We have to give in Turner syndrome. What about this cute little boy? This is an 8-year-old boy who came with short stature. He was born SGA. He has learning problems at school. The mother gave history of undescended testis, which was operated. He has ptosis, low set ears, shield chest, webbing of the neck, and he had a low birth weight and length. His thyroid profile and growth hormone are normal. The karyotype is a 46XY. The bone age is 2 years delayed. There is pulmonary stenosis by the echo. What's your diagnosis? Thank you very much. This is the Noonan syndrome. And be aware that Noonan syndrome is not uncommon. It is there, but we do not suspect Noonan. Everybody thinks of Turner. There is Noonan syndrome, and it's very common in Egypt. So, to give or not to give growth hormone? To give. Thank you very much. Noonan is one of the FDA-approved indication And recently, in 2020, it is approved in Europe. The dose is higher than the normal and sex steroid replacement therapy if there is delayed puberty. What about this sweet boy? This is a 4-year-old boy who came with short stature, very short. His birth weight was very small, 850 grams. A very low birth length, 42 centimeters. Triangular face, frontal bossing, leg length discrepancy, café au lait patch. Thyroid function, growth hormone, celiac screening, normal. Karyotype, 46XY. 2 years delay in the bone age. What's the diagnosis? Thank you very much. This is the Silver-Russell syndrome. The same question, to give or not to give? To give, thank you very much. 2 years ago, it was not approved yet, but recently, Russell-Silver is approved indication for growth hormone under the category of small for gestational age. So it is approved indication for growth hormone therapy. Now, this is a 12-year-old boy who came to me with short stature and obesity. He was born SGA, difficult feeding, weak suckling. He had severe hypotonia. He's a floppy infant. And then at the age of 3 years, he started to develop hyperphagia, progressive weight gain, some intellectual delay, and learning disabilities. As you see, he has very small hands and feet, small scrotum, and micropenis. What do you suggest? Thank you very much. Prader-Willi syndrome. Again, Prader-Willi is not uncommon. It is there, but we do not think about it. So this is the typical Prader-Willi. And look at the chart of this boy. He was born SGA. He started to decelerate in his height. More deceleration occurred at the time of adolescence. Now, look at the weight. He started below the normal, and at the age of 3 years, he developed hyperphagia, excess weight gain, to the degree that the parents told me they have to lock the refrigerator. The child does not have satiety. He couldn't stop eating. He eats all the time. And this is the case in Prader-Willi syndrome. They don't have satiety center working at any time. There is impaired growth hormone IGF axis in Prader-Willi. There is decreased growth hormone secretion, IGF-1, and sometimes there is growth hormone resistance. In addition, there is a very long list of comorbidities that we have to screen for. Central adrenal insufficiency, hypothyroidism, low bone mineral density, growth hormone deficiency, type 2 diabetes, obesity, and obstructive sleep apnea. And that's why it's important to target the diagnosis of Prader-Willi in order to screen for the comorbidities. And this is what we did in this boy. We looked at the thyroid function. We found low T4 and TSH. The adrenal functions were normal. There was impaired fasting blood sugar and oral glucose tolerance test. Now, the same question. Would you like to start growth hormone for this child with Prader-Willi immediately? Shall we go immediately for growth hormone? Thank you very much. Yes, it is an approved indication for growth hormone, but we have to correct the thyroid function. We have to correct the insulin resistance and the other comorbidities, and then we have to go for growth hormone. So yes, growth hormone is approved in Prader-Willi. There are a lot of benefits regarding the height, the body composition, the motor function, the psychomotor development, but, and this is a very big but, we have to do a full assessment, including a polysomnography, ENT examination, correct the thyroid function and the insulin resistance. This is a 14-year-old girl with chronic kidney disease, diagnosed since 4 years. She is on regular hemodialysis. I was consulted because she is very short, minus 3.12 standard deviation. She is in Tanner stage 3, serum creat 4.4, growth hormone stimulation is not done. We do not need to do it in chronic kidney disease. Thyroid function is normal. Look at the bone age, 12 years. Now, help me with this. To give or not to give growth hormone? The girl is short, Tanner stage 3. Shall we give? Thank you very much. Yes, the answer is yes. This is an FDA and European approved indication for growth hormone therapy. And there is clear impairment of the growth hormone IGF axis in children with chronic kidney disease. And the targets here in poor growth in children with chronic kidney disease is to improve the growth velocity, the weight, the muscle function, and the neurodevelopment. And these targets are clearly achieved by growth hormone therapy in those children. So again, growth hormone therapy in chronic kidney disease is approved by FDA and Europe if there is deceleration in the height. And of course, it's very important to improve the general condition, the kidney function, and electrolytes before going for growth hormone. Now, the second part of the story, she came back to me after doing renal transplant. 3 months after doing renal transplant, of course, she stopped hemodialysis. She's still short, although better than before, and parents are requesting me to go back to the growth hormone 3 months after transplant. What do you think? To give or not to give at this stage? Who would like to give growth hormone? Can you raise your hand? Anyone would like to give growth hormone to this girl? Thank you very much. We do not give growth hormone 3 months after transplant. You have to wait 1 year after renal transplantation. If the child does not catch up, we will go for growth hormone. So again, it is not approved indication for growth hormone. And as you see, in those who do not catch up, it improves the growth velocity. But there are some reports that if you start early, it could increase the incidence of graft rejection. So we have to wait 1 year after renal transplant before going for growth hormone. And this is a 6-year-old boy with short stature, normal birth weight, normal parents, normal investigations, growth hormone, thyroid, MRI, cellular, the bone age is not delayed. Everything is completely normal. What do you think? What's the diagnosis? Thank you. This is idiopathic short stature. And idiopathic short stature is a very complex disease. It's a heterogeneous group in which the height is more than 2 standard deviation below age, sex, no systemic endocrine or nutritional or chromosomal abnormality, and there is a large proportion of children presenting with idiopathic short stature. Now, would you like to start growth hormone for this child? He is minus 2.7. He is psychologically upset. Who would like? Thank you very much. I agree with you. Yes, I would like to start, especially that the child is very short. He is not improving. He is psychologically upset. Let me tell you that it is approved by FDA, but not approved in Europe. So there is a debate whether to give or not. In USA, FDA approved treatment for ISS less than minus 2.25. It is not yet approved in Europe. They need larger doses, and it adds around 3.5 to 7.5 centimeters compared to control, because some references say they do not respond very well. So we have to calculate the cost benefit. And here you can see a lot of references assessing the response, and it's totally variable. So these are the guidelines published in 2016 by European Society for Pediatric Endocrine, taking the condition as case by case. We have to calculate the cost benefit on individual basis in those children. Now, let me end by this 9-year-old girl, another debatable case. She came to me with short stature and early puberty. She's very short, minus 2.8, Tanner stage 3. Growth hormone stimulation is normal. Celiac, thyroid, adrenal, everything normal. The bone age is advanced. The girl is 9 years. The bone age is 11 and a half. This is a very common scenario, by the way, that we see in Egypt. Would you like to wait? Would you like to give growth hormone only? Or would you like to combine growth hormone and GnRH? Let's take it one by one. Who would like to wait? Not doing... Okay, who would give growth hormone only? Only growth hormone. Who would combine growth hormone and GnRH? Yes, I agree. This is the correct decision. But let me tell you that this is not FDA approved, because some references mention that it's going to cost a lot of money. So does it deserve or not? But let me tell you, by my personal experience, yes, it improves the final height. But this is not FDA approved. And we see this a lot. So sometimes the decision is not that simple. It's really a dilemma. And not all cases of short stature are due to growth hormone deficiency. This is another very common scenario that we see at our clinic. This is a 14-year-old boy with short stature and delayed puberty. His father gave history of being very short in childhood and catched up spontaneously. This is the growth chart. He was below the centiles and decelerated more at the time of puberty. He was found to have microcytic hyperchromic anemia, lowish calcium, low vitamin D. Celiac and thyroid are normal. The GnRH test, the GnRH stimulation test revealed low FSH, LH, and testosterone. So this is hypogonadotropic hypogonadism. And look at the bone age, 10 years. Although the boy is 14, and the height age is exactly equal to the bone age. What's your diagnosis? Thank you very much. This is a very, very common scenario that we see. Now, would you like to start growth hormone? Who would give growth hormone to this boy? Thank you very much. Growth hormone is not the treatment here. We have to do reassurance, proper nutrition, correct iron, calcium, and vitamin D deficiency. Sometimes we give a very low dose of sex steroid to initiate the growth spurt to improve the final height. And this is what we did here. The child catched up his height. And let me tell you, he's taller than his father now. So finally, please remember, early diagnosis and proper treatment of short stature improves the final height outcome, whatever the cause. And what if the time is critical? Correct decision of prescribing growth hormone is very important. And when prescribing growth hormone and time is tight, efficacy of growth hormone counts a lot at this period, because sometimes we need to buy the time. Sometimes it's very tight and we have to interfere to avoid this very sad story that I see every day. An adolescent coming to me with short stature, and when we do the bone age, I say, I'm very sorry. There is complete epiphyseal closure. I couldn't interfere. And unfortunately, we cannot go back with the time. So starting early is very important, and choosing the correct type of growth hormone is very important. I hope I was able to answer this really challenging question when dealing with a short child, to give or not to give growth hormone. I'm a very big fan of growth hormone. I agree it's a magical stick, which treats a lot of cases of short stature, but not every case of short stature. So it increases the height, I agree. It improves the metabolic profile, yes, agree, but it's very important to use growth hormone wisely. We should calculate our steps very well. I'm pressing again, these are the approved indications for growth hormone therapy in children and adolescents that we must go for and prescribe growth hormone as early as possible. On the other hand, we have to think twice before prescribing growth hormone in the off-label indication. Don't take it so easy to write down growth hormone. The list is growing and there is more to come. We are seeing growth hormone prescribed in other off-label indication. We have to balance the decision, and we have to treat on individual basis, like the cases that I showed you. And please avoid growth hormone abuse. A lot of men are taking growth hormone in gymnastic holes in order to make more muscles, and a lot of ladies take growth hormone as an anti-aging. And some people take growth hormone to decrease the belly and the abdominal fat. So this is abuse of growth hormone. And this is an off-label indications that should not be applied in growth hormone. And Forever Young, a lot of celebrities are taking growth hormone to stay young, pretty, and beautiful. For various purposes, they are taking growth hormone, including our lovely artist, Yusra. She's staying young and lovely, although she's 70 years because she's taking growth hormone. But of course, this is an off-label indication. I'll end by this very nice quote that I believe in by Philip McGraw. Sometimes you make the right decision, sometimes you make the decision right. So I think we as doctors and endocrinologists have the duty to make the decision right by prescribing growth hormone properly, choosing the right case, the right growth hormone at the proper time. So always make the right decision at the proper time in order to hit the target properly. Thank you very much.